and good morning. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. We're here at the Duke Spine Institute today doing spine surgery live and broadcasting on YouTube, Facebook, X, and Twitter, LinkedIn. Henry, do we ever find out about this?
I don't. It has to comply with Restream, and so that's where we're talking about Truth,
Truth.
the app, and so yeah, it's got to comply with Restream, and so that's when I'm just still trying to figure out if that is still possible to put the URL address on Restream for Truth.
Let's try to do that.
Yeah.
All right. This patient actually has back pain coming from several different areas. Now, she had surgery on her L3-4, L4-5. On the left side. I was about to say that, On the left side in the past, she's had facets treated on the left. Now she has pain on the right side. So she's here with facet pain at L3-4, disc pain at L3-4, herniation on the right side at L3-4, pinching the nerve, but she also has severe piriformis muscle syndrome. We're going to be fixing this in the next surgery, same surgery, but we're going to stop our stream and come back. We'll be broadcasting the piriformis releases. Right now, we're going to fix the disc and the facets at L3-4 on the right side. So once again, L3-4 is the problem on the right side, and the facet joint is the other problem. There's pain coming from that as well. So right now I'm going to access the disc at L3-4 from the right side. To do that, I need some num-num. We're going to numb up the tissues. Now, this surgery you're watching is laser spine surgery. And this is a unique type of procedure pioneered by me at Duke Spine 18 and a half, let's just say 19, almost 19 years ago. And we've been performing it the same way for 19 years because it works. We don't want to change something that actually works. She comes to us from Idaho. And she's here with her husband, who brought her to the surgery center this morning. Sean? All right. We're trying to make our way to 3-4 on the right side. You guys can see that up there on the x-ray. Henry, are you seeing the x-ray shot?
Of course.
Good. And I'm just passing her facet joints right now as we speak. Shot. Okay. You can see the needle. You can see the facet joints. I am going to try, I'm hitting the facet, which is what I want. Shot. And I just want to sneak around. Shot. Shot. I want to be just a titch higher. So I'm going to redirect just a titch higher. You guys like that titch word? I think that's I'm not sure the origins of titch, but it means a small amount. I will tell you this, her spine is quite posterior, which is good for her and me. It makes my job a little bit easier. Shot. Shot. How is she, Dr. B? Is she awake? Shot. AP. That looks really good.
How are you? You okay? She said okay. We're going to ask you a few questions. You're doing great.
All right. Very good. So we're a bit lateral. We need to be a little bit more. See, her spine is curving away from us. That's why. All right. So I'm going to start again. I'm going to come out a little bit and start a little bit more medial because her spine is curved away. Go ahead and put pressure there. All right, let's try this again. Shot. You guys saw how curved the spine is. We are not here to fix scoliosis. We're not interested in fixing scoliosis. That's not causing her symptoms. Her symptoms are coming from a disc and a facet. Shot. All right. So because of the scoliosis, I have to start a little bit more medial than normal. AP, let's just see where we are.
So scoliosis is not classified as one of the 30 causes. I'm just curious on
Scoliosis is not a cause of back pain. It does not cause back pain. Scoliosis itself does not cause back pain. All right, go back to a lateral view. So I'm still a little bit too far to the right side. Yeah, I need to get over more. How is she doing? Hang in there. You're doing great. We're just trying to get to the disc so we can fix it. She's sleepy but awake. You're doing awesome. Just hang in there. Shot? All right, that's got to be the facet. Just lay still. You're doing really good, Shot. Uh-huh. That's probably a little bit too shot. It's too posterior. Shot. It's very important to get exactly right. Shot. All right, let's get another AP. So Jordan has done a phenomenal job of lining up the spine on the x-ray so that I can navigate to where I need to go. Still too lateral. All right, so I'm going to have to move even more towards the midline to get to her spine. You're okay. Put a little more numbing medicine here. If you have questions, feel free to ask. The first step in fixing her disc is going to be to get into the disc so I can repair it. And normally we wouldn't start this far to the other side, Shot, but because her spine is so scoliotic, it's pushed her everything over to the left. And I'm on the right side, remember, Shot? Lay still. All right, let's see where that is. Hopefully we're a little bit more off to the left. If you have questions, feel free to ask. This first part of the surgery, we have to get into the herniation from the right side. Yeah, we're hitting the transverse process. That's the problem. All right. You're doing great. So the bone that I'm hitting is not the facet, it's the transverse process. You can see it on the AP view. That's why we do an AP view. I'm going to try coming from a little bit higher position. We numb this area up so it will be more comfortable for her. You're okay. I'm just trying to get in to where the problem is. All right. Yeah, you're doing great. Just lay still. Shot? Some people want to know, why does the patient need to be awake? AP? Well, the reason is simple. We're moving around with the needle just around the nerve roots, and we need to make sure that we don't get too close. She'll let me know if I'm too close. AP? Oh, that's much better. Much better. Okay, we're almost there. You're doing great. Hang in there. Your scoliosis has made it very difficult to get to, but we're going to get there. Don't worry. We're almost there. Just hang in. I just need you for another minute, okay? That's the herniation I'm touching right now. That's why it's bothering you. Shot? We're right on the herniation, literally on the herniation. Shot? All right. You're doing great. Is she awake?
How you doing? You okay? You all right? Okay. We're going to ask
Shot?
you some questions now. She's awake.
Man. Is she comfy? I need an AP. I'm right there at the back of the disc herniation, and I'm trying to get into the disc space. And as you can see, the scoliosis is definitely having an effect. Yeah. All right, back to a lateral view. You can see we're in a perfect position on the AP view. We're right at the interpedicular line, the line between the center of the pedicle above and below the disc. And now I just have to get into the disc, and I think I just need to be having her relax a little is going to allow me to get in. Don't move. You're doing awesome. We're almost done. Man. Jordan, you're doing something wrong on the lineup there. I don't know why. I mean, it looks good to me, but I'm not able to get into the space. And I'm wondering if it's not off just a little bit on the x-ray. Can you get the end plates lined up? You see how the body below is off with the pedicles? So L4 is off. Shot. That's worse. Go the other direction. 5, 4, 3. We're definitely at the proper disc space. Other way. I don't know if you have to move your base. See those pedicles are just off, completely off. Yes, those two. Let's try to get them lined up. This is what scoliosis does. On the lateral view, you can have a pedicle at the vertebral body above where you're operating. It's perfect. And then you look at the pedicle below and it's completely off. That may just be the best we're going to do. I don't know. It's interesting. But I am having a lot of resistance to get in, which is not normal. I don't know if it's just scar tissue or if it's... Oh, there we go. All right. So we're just shot. Let's see. That looks good. Is she ready? We're going to just test the disc to verify.
I'm going to ask you a question, all right? You doing all right? Okay.
Is she comfy?
Don't move. She's comfortable. Don't move.
She's awake?
You doing all right? You're awake? Huh? You okay?
You all right?
She's moving her hands. Yep. Okay. I'm right here.
Well, I'm going to give her another minute. While I'm doing that, we're going to move on to the sacrum. And I'll show you guys where the piriformis muscle is, because that's what we're fixing next. We're not going to do it during this stream. We're going to stop the stream and come back. The piriformis muscle, common cause of top of the buttock pain, attaches to the hip right over here. This is the hip. This is the piriformis muscle. And basically, the piriformis muscle is the main cause of back pain. There's no disc pain, no facet pain, it's just piriformis in 3% of patients. However, the piriformis is a cause of chronic back pain along with the disc and facets in around 30% of patients. Piriformis, okay? So, if you have chronic back pain, you have a 1 in 3 chance that you also have a piriformis syndrome. Is she awake?
Yep.
You awake?
She's awake. Yep.
All right. Are you having any pain? You having any pain?
No, not right now.
There we go. How bad is that on a scale of 1 to 10?
Move.
Look at that. How bad did it get?
What number?
10? I heard 10 over 10. Is that where you get your pain? Yeah. She said, uh-huh. Okay, so we just verified that the L3-4 disc is the cause of her back pain that she's here with. She's having pain coming from here. She's having pain coming from here and here. So we're going to fix the disc right now. Then we're going to end the stream. We'll come back and fix her piriformises. If you have questions, feel free to ask them. In the meantime, we're going to get started on our Duke laser disc repair. Lay still. You're doing great. We're going to make a 7mm incision. Tiny incision. The nice thing about the surgery is there's almost no bleeding that is occurring with the surgery. We'll lose a few drops of blood typically, but no more than, say, a nosebleed. If you have invasive spine surgery, you're going to lose a lot more than a few drops of blood. Man. If you're doing this type of surgery, you got to be careful. If the patient has osteoporosis, you don't want to fracture their vertebral body. And that's one of the beauties of this type of surgery is that if you're doing invasive surgery, you have a high chance of fracturing the vertebral body and causing a fracture of the spine, which we don't want. But if you're doing endoscopic surgery like I am, the chance of fracturing the vertebral body is very low. I mean, virtually zero. I've never had a fracture of the vertebral body, but it's always possible. It's much more likely with laminectomy, discectomy, fusion, artificial disc, especially in a patient with osteoporosis. Okay, how is she?
Okay.
Nice and sleepy? Hold on, that's good. So we're hammering in what's called the dilator. The dilator is a tool that spreads tissues apart. It doesn't cut. You see I had to cut the skin to get it in. That's because the dilator does not cut any tissue. The only trauma we're doing to this patient is cutting her skin 1/4 inch. The rest is all spreading tissues, much like if you had a pin that you're wearing, like a political pin, let's just say. Let's say you had a pin on your lapel. You push the pin through, right? And it doesn't cut your shirt or your dress. It just spreads the cotton fibers apart, or whatever it is you're wearing, rayon, cotton, polyester. The point is, the pin never cuts your clothing. It just spreads the fibers apart. When you take the pin out, the fibers come back together. Everything under the skin is fibrous. And so we're not doing any damage to her. That's why these patients don't require narcotics after surgery. We don't cause trauma to their body in any way. We are literally just cutting the skin. And if you get a skin cut this big, you don't need narcotics. Now, if you had a laminectomy, then you're going to need narcotics. Henry, let's show the audience what a laminectomy looks like. So we're not doing a laminectomy, we're doing a much less invasive procedure, but we want to show you what a laminectomy looks like. Do you have that video?
Of course.
Welcome back. And that was a laminectomy we showed you. We're not performing that. That's an invasive surgery. But with that type of surgery, which we don't recommend laminectomies at Duke Spine anymore. It's an old surgery. It's 100 years old. It used to be done for taking tumors out of the spine. For that type of surgery, you have to be on narcotics because there's a lot of damage being done to your body. Avoid laminectomy. This is a much safer and better treatment. So far, I've been pulling out chunks of herniation like this piece right here, and Luis is collecting them for you. I'm going to show what we've got so far. But we are in the 3-4 disc, L3-4. This is a L3-4 herniation on the right side, and you can see at 12 o'clock there's some inflammatory tissue with a little bit of blood clot. That is where her back pain is coming from. That's the inflammation in the posterior annular tear. Now, there are 30 very common causes of back pain. Some of them are more common than others, and we have a nice video that shows you all 30 causes of back pain that cause chronic back pain, which is pain lasting more than 2 weeks. Henry, let's show our audience the 30 different causes of back pain.
Of course.
I'm Dr. R. Deukmejian with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us.
Welcome back. What a great video. You can see from our video that there's more than one cause of back pain. And I'm just going to say back pain, but I'm referring to chronic back pain. Chronic back pain is pain that people get on and off for over 2 weeks. And it affects millions and millions of people worldwide, probably over 100 million people worldwide. So the most common cause of chronic back pain is a disc injury. And you know those disc injuries as herniation, bulging, rupture, extrusion, protrusion, slip disc, spondylitic disc, degenerated disc. They're all the same thing. They're just different stages, okay? Kind of like a human being, right? We have stages that we go through where we
where I want to show you the incision. We're going to put just 2 little staples here. Now she's from Idaho. We're going to get her staples out tomorrow before she leaves. I want to show you the herniations. So disc injuries are 85% of chronic back pain, 85%. This is a 7 millimeter incision. It's really a 1/4 of an inch. You guys see that?
Yes, we do.
1/4 inch. And we just fixed the disc. Now we're going to work on her facet joint. But I just wanted Henry, to show you guys how is it that a disc injury like that, an annular tear during a herniation, how is it that that could be so painful, and how do we fix it with the laser? Meanwhile, we're going to get ready to do our facet treatment because she has facet pain as well. So go ahead and show the audience how a disc injury causes back pain and how we treat it with laser.
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4 inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Thank you, Henry. Henry has graciously shown us a video on how we fix back pain. 85% of back pain is coming from a disc problem, and that is the most common treatment we do at Duke Spine. We just finished that with this young lady. Next, we're going to move on to facets, and that's what I'm working on right now. She also has facet joint pain. Not a big surprise. You could see from the scoliosis that her spine is twisted, and it's putting a lot of extra pressure on these facet joints here on the patient's right side. Shot. So I need to get down to the facet, which is right there. Jordan, show the audience where the target is for the nerve. I mean, you could see it right where the tip of my probe is. It's perfect. Show us the pedicle. No, the pedicle, yes. Show us the lateral wall of the pedicle. It's cortical right there. Show us the transverse process. Looks like a finger pointing. And where the transverse process and pedicle meet at the top margin, right where the tip is, that is exactly where the pain nerves live. And that's what we're here to destroy, is that pain nerve. Just about done. To answer the questions that have been asked by Ping, you do not wear a collar, like a cervical collar, to correct scoliosis. It doesn't work. And we do not prescribe pain meds to patients. We're not really a pain med clinic. We're a fix your problem clinic. We don't give our patients pain meds because they don't really need them. Watch your fingers. All right. We are done with our Duke plasma rhizotomy, and now we're going to put some staples here, but that incision is 4 millimeters. I may have made it a little big at 5 millimeters. Luis, let's show the audience the disc material, the herniation that we took out of her disc. Remember, she had an annular tear, like you saw in the video. Oh, Luis already sent them out. I think there's one piece right here.
But this is an example of what a herniation looks like, okay? You guys see this, Henry?
Yes, we do.
Mm-hmm. And the important thing to note here is they're different sizes, okay? You have some small pieces, you have some large pieces. We've had some that are 3 centimeters or even longer occasionally. So the herniation fragments of nucleus that come through the annular tear and sit in there and cause all that inflammation and back pain, they vary in sizes, but the average disc has around 25 pieces of herniation that are causing the symptoms and need to be removed. All right, we're done with the DPR. We're done with the DLDR at L3-4, L4-5 on the DPR. And now we're going to turn our attention to the piriformis muscles. We'll start with the right and then we'll do the left. So let's go ahead and end the stream and we'll bring you back in a moment to do a piriformis release.
Copy that.